We are live now.
Hello, good evening, everyone. I am Dr. Ashish Phadnis. I'm the Organizing Secretary of Wiroc Wax 2022 this year. And I welcome you all to this curtain raiser, which leads up to the run up to the Wiroc on the 29th to the 31st of December 2022. Today's episode, we are going to talk about the era of subspecialization. As we talk about the genesis of Indian orthopedics, we look back on the achievements of an orthopedic surgeon, on our contributions of our orthopedic surgeons from our society, and where they have raised the standards of orthopedics and got us here where we are. We, the Bombay Orthopedic Society, are at the forefront of motivating each other, innovating solutions for our patients, and integrating them into our practice. Today, we look at four such speakers who have, over the years, forayed into an era or forayed into a specialty of their interest where they were sort of the early movers and they took the challenge on themselves to find solutions, to train themselves, to train others, and to bring to our shores the technology, the technique of these various subspecialties that they are very well known for. It gives me immense pride and pleasure to announce the four names. Is we will be with Dr. Anant Joshi. We'll be hearing about his journey in arthroscopy. Dr. Arun Mullaji, who's a senior arthroplasty consultant and whose name is synonymous with arthroplasty, will be talking to us about his journey in arthroplasty. We'll be talking to Dr. Mangal Parihar, who has sort of made an unparalleled name for himself in the field of deformity correction, non-unions, using external fixators, ELISA rows, and adapting them in our sort of practice, innovating and suggesting innovations to sort of constantly make it better and better. The last speaker would be Dr. Ajay Puri, who was and is a very formidable name, a very well published figure, and a key opinion leader on matters regarding orthopedic oncology. These four doyens of orthopedics are the ones who sort of have heralded or were the leaders in the era of subspecialization. Having said that, wasting no further time, I would like to invite the president of the Bombay Orthopedic Society, Dr. Rajesh Gandhi, to welcome you all for this curtain raiser. Over to you, sir.
Dear friends, colleagues, my teachers, and my orthopedic colleagues. Today, in the third episode of the curtain raiser to Wiroc 2022, we are going to talk about era of super specialization or a subspecialization. Well, I remember when I started my practice, there was hardly any specialization. Everyone used to do everything. We would do trauma, we would do spine, we would do occasional joints, etc. Then there was a resurgence. Gradually, people started doing specialized work. That is how the super specialization has developed. I do remember a word spoken by Dr. Tarapurva. He used to say, a time is not far when people are going to treat right little toe. Means he was talking about, basically what he was trying to convey was that it is going to be so specialized that people are going to treat micro things together. That's the way it is. It has come to an era. Today we are seeing people who are doing different organ specialization. There are people who are doing a shoulder joint or surgeries only. There are people who are doing upper extremity, people who are doing joint replacements, people who are doing deformity corrections. So today we have our panel for discussion, a very eminent panel, Dr. Anant Joshi, Dr. Arun Mullaji, Dr. Mangal Parihar, and Dr. Ajay Puri. All they are going to talk about is the specialized work which they are doing. And I hand over to Dr. Ashish to take over, to take them through further. Thank you.
Thank you very much, sir. And we begin our program with one of our very dear colleagues and surgeons and mentors, Dr. Anant Joshi. Uh, Dr. Anant Joshi is not a new name to anyone. A sportsman at heart, he was instrumental in establishing the Arthroscopy and the Sports Medicine Institute at Dadar. He was the sports physician to a lot of well-known cricketers and sports persons in the country and abroad. And he has sort of, inspired an entire generation of people who were interested in sports and orthopedics. He was at the forefront of arthroscopy when very few people were doing arthroscopies. And we all remember as residents lining up and waiting for Dr. Joshi to sort of give us a slot where we could go and observe him, do his surgeries, and share his experiences. So I will very warmly welcome Dr. Joshi, who is now the director of Sports Med Institute at Parel, to take us through his journey on arthroscopy. Over to you, sir.
Extremely grateful to the organizers of this Wiroc 2022 for this invitation to share my journey in arthroscopy in this curtain raiser. In the late 70s and early 80s, as a resident in orthopedics, diagnosing an internal derangement of any joint was a challenge. Treatment was more or less formulated. For example, in the knees in the 80s, if the patient came to us with a swollen knee, it was aspirated. If the knee was not swollen, it was injected. If it was too painful, it was immobilized in a Robert Jones bandage. And if the knee was locked, it was kept in traction. However, all this changed with the arrival of this so-called magic wand, the arthroscope. Arthroscopy, the endoscopy of joints, not only allowed us to have a look into the internal joint, but also helped in carrying out a majority of surgical procedures with minimally invasive techniques, overcoming the shortcomings of open joint surgery, which involves scarring and restriction of joint motion. My first exposure to arthroscopy was way back in 1981, when the pioneering arthroscopist Dr. Dinesh Patel from Boston delivered a talk at the JJ Hospital on this magic wand, the arthroscope. However, as residents in those days, being used to three-dimensional surgery of open joints versus a two-dimensional approach of arthroscopy or perspective of arthroscopy was entirely unpalatable and unappealing, not just to the residents, but to my bosses as well. And it was very difficult for anyone to even think that arthroscopy could be the game changer of the future. Dr. Patel, known for his mid-patella lateral approach in those days and extensive work on the plica syndrome, was very keen that arthroscopy comes to India. He persuaded a number of surgeons from the city of Mumbai and the rest of the country to visit him in Boston. The late Dr. Praveen Vora was my chief in orthopedics at that time at the JJ Hospital. He was very enthusiastic about learning arthroscopy. He went to Dr. Patel and came back with an arthroscope in his suitcase. However, what happened next was a completely kind of surgical exercise, which for us residents was pure torture. During these days of direct vision arthroscopy, it was only the surgeon peering through the scope who knew what was happening inside the joint. As residents, we were forced to hold the limb, maneuver the leg in flexion, extension, varus, valgus, and at the same time having our second bath of the day like everybody else in the OR. At the end of this surgical exercise and after multiple attempts at arthroscopy, we then had to correlate with arthrotomy. And this was definitely in variance with what was diagnosed arthroscopically. So arthroscopy really did not catch the fancy of most of us in those days. In the early 80s, of course, it was a much maligned surgery. The traditional surgeon always believed that big surgeons make big incisions, bigger the incision, better the surgery. And they also used to taunt, saying that why look through a keyhole when you can open the door? Even in the US, where arthroscopy was on the upsurge in those days, there were surgeons who were skeptical about arthroscopy. In fact, Charles Rockwood had put up a note in his operating room saying that the arthroscope was a tool of the devil. And in those days, in the 80s, we definitely concurred with Rockwood's observations. In 1982, I happened to enroll for a course in sports medicine at the United States Sports Academy, having not the slightest inkling that I may take to arthroscopy in the future. However, it so happened that one of the professors in sports injuries, Dr. Fondren, who I regard as my guru in arthroscopy, coaxed me into seeing arthroscopy the way it was practiced. And I suddenly realized that this was a completely different ball game than what I had seen or what I had experienced in India. Dr. Fondren was instrumental in training me. The basics as well as the advanced, he was excellent. He, in fact, in those days, in the 80s, he always used to insist that we need to look at the posterior compartment of the knee. I took to arthroscopy and now it has become my passion. However, setting practice in India in the 80s was not easy. We had a closed economy with the license Raj, where one had to have various kind of licenses to import medical equipment. Foreign exchange regulations were extremely stringent. Loans were not easy to come by. We did not have vendors to sell and support high-tech equipment like medical equipment like arthroscopy. The duty structure was at an exorbitant 200%, which was definitely a deterrent. So I had to resort to fraudulent foreign exchange transactions, false customs declarations to smuggle in my arthroscopy equipment. In India, those days, the laparoscope was probably the only endoscope which was recognized because India was on a warpath of sterility. And so arthroscopy equipment was brought into the country as laparoscopic equipment. I set up my first daycare surgery center in 1986 with the complete equipment required for video arthroscopy. And in those days, I used to record the surgical findings of each and every patient. And this has been our practice from day one. We initially started with video cassettes. We then went on to CDs and later on to now the USB sticks. Maintenance of any kind of malfunction in this equipment was not at all easy in those days. If my camera failed or if my shaver system conked off, either my wife or myself had to rush to Germany over a weekend to get it fixed and return so that the work at the clinic did not shut down. Of course, to set up practice in a subspecialty or a super specialty like arthroscopy needs a lot of backing. I must say that there were quite a few surgeons who backed me wholeheartedly during my struggle in setting up my practice in arthroscopy. Dr. Pachore of Bombay Hospital, Dr. Dholakia, Dr. Chaubal, and of course, Dr. Nandulad, whom I regard as my godfather. He was the one who told me that if you stick to arthroscopy, I shall at least send you one patient every month. And that was enough for a beginner who was just starting practice. In those days, surgeons who came back with arthroscopy equipment to get back returns on investment did various kinds of surgical procedures like plica excisions, unwanted surgeries like osteophyte excisions, which were not really hindering any joint motion, and of course, joint lavage followed by an injection of a steroid in the joint was extremely popular. Fortunately, I did not indulge in all these. Another very popular procedure in those days was the so-called abrasion arthroplasty. It was believed by most surgeons that if you removed articular cartilage and restored joint congruency, normal articular cartilage would be regenerated wholly and joint replacement could be avoided. However, as we all know, this does not happen. And in fact, in those days, a number of patients became worse after abrasion arthroplasty and their joint replacement was preponed. Of course, again, logic did not apply and I did not take to abrasion arthroplasty in those days too. I progressed in my arthroscopy skills in the late 80s when I started my scopic work. It was mainly excisional surgery, removals of loose bodies, removal of menisci. But we soon realized that a number of athletes came back repeatedly to us with unstable knees, and we did not have an answer to that. By 1989, the ACL reconstruction techniques had so far been stabilized, and I then moved on to repairs and reconstructions. Repairs being the menisci. In fact, we also did some reattachments of the ACL during those days, and of course, reconstructions. In those days, the bone patellar tendon bone was the gold standard, and we gradually moved to the hamstring tendons, the quad tendons later on as we progressed in arthroscopy. I graduated from one joint to the other, moving from the knee to the shoulder, to the elbow, and even the ankle. However, I did not have the courage to dabble with the hip and nor the inclination to fiddle with the knee, with the wrist. During my first 20 to 25 years of practice, I traveled extensively across the length and breadth of India, not just doing arthroscopy camps, but teaching at various places. And this helped me tremendously in developing camaraderie with a number of my orthopedic surgeon colleagues from all over the country, as well as developing a real base for my arthroscopy practice. I continued my quest for learning. I visited surgeons all over the world, in the US, in Europe, in various parts of Asia, like Korea. I had the fortune of learning ankle arthroscopy with Nick Van Dyke. And even I did not hesitate to learn from younger surgeons like Feng Hua, who unfortunately is no more with us. As far as equipment was concerned, I kept on upgrading my instrumentation. Here was my OT in the initial days in 1986. And here is our OT today with a 4K system, a laminar airflow, and probably a state of the art, which is comparable to anywhere in the West. If I were to analyze as to why I was successful in practice so far, I feel I did not develop a tunnel vision of arthroscopy. I always believed that there were other techniques which were equally important for us to preserve a joint. I believed in the role of osteotomy, realized that surgery was not the panacea, nor was arthroscopy as a panacea for all joint problems. I treated symptoms and not signs or images, and operated only if I felt that the patient would have a long-term benefit after the arthroscopy. I resisted the temptation of jumping onto the bandwagon of any new technique without having tested it myself or unless it appealed to my logic. So I did not jump into the double bundle ACL, nor do I believe that the anterolateral ligament should be done in all cases of ACL, nor do lateral extra-articular tenodesis procedures are required in all revisions. I also have not taken wholeheartedly to repair of all and sundry meniscal tears and have not become a meniscus fixer. Along with my growth in the development of arthroscopy, I think the Indian Arthroscopy Society has played a major role in development of arthroscopy in the country as a whole. Established in 1983 with a handful of members, we have now progressed to being one of the largest subspecialty in IOA with 3,300 members. The Indian Arthroscopy Society offers traveling fellowships, both domestic as well as overseas, for training of local surgeons. And the IAS sponsors courses not only in metros, but in second and third tier cities as well. The growth of IAS can be attributed to tireless work by some of the founder members of this association, Dr. David Rajan, Dr. Nicholas Antau, and today to the dynamic secretaries that we have like IPS Oberoi, Armugam, and some of the secretaries like Dr. Roshan Wade. Indian Arthroscopy Society has been instrumental in setting up a lot of cadaveric workshops, which I feel are the key to developing skills and techniques of arthroscopy. We have some established and structured courses at the Ramchandra Institute in Chennai and also at Ramaiah. We also have simulation models at IMAST in Mumbai. Even in a second tier city like Kolhapur, we have cadaveric workshops on a regular basis. Arthroscopy has progressed and so have our arthroscopists. Today, the Indian arthroscopy scopist has made his presence felt on the world stage. Today, they are not just presenters, but they demonstrate surgeries on the world scene. They are not just publishing papers, but editing books. Two of my colleagues have edited books which are on the absolutely international standards. Industry has played a great role in the upliftment of arthroscopy in the country. But in the recent years, because of the Make in India push, we have found that Indian companies themselves also have started competing and producing equally effective products as the international ones. So what do I foresee in the future for arthroscopy? I think just like our arthroplasty colleagues, we will probably see the robotics being gradually coming in for arthroscopy, probably helping us in better fixation or better localization of our ligamentous reconstructions. And also, maybe we will look from the more biological perspective of our reconstructions, and we'll have more and more of orthobiologics and regenerative medicine to address some of the vexing issues of articular cartilage and biology in some of the reconstructive procedures that we do. Thank you very much.
Thank you very much, sir. That was very insightful. And important take-home message is that, not to make our patient a fashion victim, and basically to try and test the technology yourself before you impart it and adopt it as a clinician. From joint preservation and arthroscopy, we move on to arthroplasty. And who else to take us through that than our Dr. Arun Mullaji. Dr. Mullaji is a senior and a very well-known face in the arthroplasty circles, a very well-published surgeon who has got a couple of books to his name. He is a designer surgeon for a couple of implants, and he's a perfect match of someone who is motivated, innovated, and adapted or integrated that into his practice. Over to you, sir. We are extremely thankful and proud to welcome you on board here. Dr. Mullaji.
Hello. Thank you for asking me to be part of the curtain raiser for this most eagerly awaited Wiroc. I've been asked to speak on arthroplasty at its best, looking backwards and looking forwards at orthopedics in India. The metamorphosis of arthroplasty in India is something that we've witnessed over the last 50 years. We've been fortunate to stand on the shoulders of giants. Dr. K.T. Dholakia did the first total hip replacement 50 years ago, and a few years later did the first total knee replacement. We've had several others who have been giants in this field and who have contributed immensely both in the past, and we currently have a large number of surgeons in India performing arthroplasty and who are at the cutting edge and the forefront of this very exciting field. However, when we look back over the last 50 years, arthroplasty has undergone a marked change. I remember when we were doing a hip or a knee replacement in the past, it was a big drama. Patients used to be skeptical, the surgeons were quite dubious and quite lacking in confidence. Patients would be told, do this as a last resort. When you stop walking, come and have a replacement surgery. Most patients would stay for 3 weeks. They would be on antibiotics for at least 2 weeks. After a hip replacement, I remember even Dr. Dholakia himself, when he had a hip problem, had a boot and bar for 2 weeks post-surgery. Staged bilateral total knees were a rarity. We routinely used 1 or 2 drains, tourniquets, CPM machines, blood transfusions, and if the knee got infected, then that patient ended up with a fusion, possibly with a long nail or an Ilizarov fixator. Let's see what's happened in the last 50 years. And these are the 5 areas that I would like to focus on. One is the development of evidence-based techniques. Based on this, now we use tranexamic acid, and as a result, we've stopped using tourniquet, drains, and blood transfusions are extremely rare in unilateral cases, even in bilateral unis, and only occasionally in bilateral total knees, especially rheumatoid patients, do they require blood transfusion. We've stopped using drains altogether and don't use a tourniquet. Most of our patients, over 90%, would be in a position to go home in 24 hours. This is an example of a bilateral uni on the left and a bilateral total knee replacement on the right side. Thanks to minimally invasive techniques, very guarded or minimal soft tissue releases, perfect balancing and alignment, and pain control measures along with patient selection and education, we've been able to discharge patients very rapidly. Personalized arthroplasty is now very common. In fact, compartmental arthroplasty is being more and more commonly performed in India. In my own practice, nearly half my cases are compartmental arthroplasty and the other half would be total arthroplasty. We have realized that the ACL is the key, and thanks to better imaging techniques, we are now able to assess the cartilage very accurately and determine what is the extent of involvement, so we can just do a cartilage or a compartmental arthroplasty. This is an example of a patient in 2003 where I had done bilateral medial compartment arthroplasty. 19 years later, these are her x-rays. No loosening, no lysis, no wear. The other compartments have remained perfect, and this is her range of motion and gait. Technology in arthroplasty has come a long way now, and in fact is one of the fields which is extremely exciting, with the advent of a whole host of different technologies being employed for the betterment of our patients. For example, we now have detailed planning which allows us to do personalized placement of components, of alignment, of soft tissue balancing. CT, MR based and even CT free planning can be performed. We have realized that all limbs are not the same, and that we've described different phenotypes of both varus knees as well as valgus knees, with subtle variations in the diaphysis, epiphysis, metaphysis, in the joint line, obliquity, extra-articular deformity. And in order to cater to these variations in phenotype, we need special navigation tools such as PSI, computer navigation, and robotics. Way back in 2011, we used an iPod for the first time in the world to perform knee replacement. And now 10 years later, a company has actually introduced a handheld smart tool for knee replacement surgery, which very much resembles the iPod that we had used. We also have now the third generation robot, which allows us great accuracy in alignment and balance. Nevertheless, there's a mismatch between off-the-shelf implants and the patient's anatomy. There's a shape mismatch between the bones and the implants being used. And this has set off a whole new industry of 3D printed custom implants and jigs. And there are different methods by which this is performed, either by casting or 3D printing. And these are made to the patient's dimensions, and the bone shape and size is taken into consideration. This is an example of one of our patients who had this periprosthetic fracture, very osteoporotic bone, and here we've used a 3D custom printed titanium cone which we've used to take care of this very complex problem. There's another patient who underwent loosening of the tibial component on the left side, where again we've used a custom 3D printed cone for this particular patient. We're also now able to do individualized ligament balancing. This is a patient with a very severe deformity of nearly 30 degrees with very severe soft tissue imbalance. And with navigation, we can now precisely titrate our soft tissue releases, component positioning, so that we have perfect alignment and balance. We're also now able to use sensors which are present in the trials to allow us to do the same soft tissue balancing maneuvers. Implants themselves are now smart implants, and they have transmitters in the stem which gives us more details about the cadence, step count, gait, etc. Cementless fixation now is very common in hips, but now is also becoming more common in knee implants. Nanostructured surfaces are now being available which allow more osseointegration, and they also have antibacterial properties to reduce the risk of infection. In fact, there are now drug delivery systems which are based on nanotechnology, which can release the drug on contact with the bacteria. In addition, we now have wearable sensors which allow us to monitor the patient's function after surgery. And lastly, I'd like to talk to you about a paradigm shift in the treatment of infected total knees. These are becoming more and more commonly seen as knee surgeries are being done all over the place. In the past, this patient would have received perhaps a fusion with either a long nail or an X-fix. Now, however, we can do a one stage. In the first stage, we do a thorough debridement and insert a spacer containing antibiotics. This is an articulating spacer, So in the meanwhile, the patient can walk, bend the knee, and lead his normal life. And then at the second stage, when we are sure the infection is cured, we then remove the implant and put the final implant. We have gone even one step further, and we can now do this in one stage in selected situations where we know the bug. If the patient is not immune compromised, we then excise the scar, do a thorough debridement, wash it out with large amounts of antibiotics, and then we re-drape, re-prep, use a new set of instruments, and then re-implant a new prosthesis. So now if we look forward to what is in store for arthroplasty in India, how do we ensure the success of this wonderful domain of arthroplasty? As those who perform arthroplasty know, it takes years to perfect the art and science in order to get the right cuts, balance, perfect fixation, and have a satisfied patient. Arthroplasty is now being performed in every nook and cranny of this country. But there are certain worries. What are the OT conditions? How well trained are the surgeons and the ancillary staff? Are the implants of a satisfactory quality? What about the indiscriminate use of antibiotics leading to resistant organisms? We are seeing an epidemic of infections, loosening, and instability. And will this reverse the trend of the increasing popularity of arthroplasty? On the other hand, we look for easy solutions, and now we are seeing more and more seductive tools and techniques being hurled at us. But remember that not all innovations have been successful, like the metal on metal debacle. Not all techniques will be successful. This shape match cutting guide had to be recalled by Stryker. Kinematic alignment is yet another technique which is now being commonly promoted. We ourselves have written a cautionary note as an editorial saying that it's important to have a safe zone concept and not go to these radical alignments. Do not depend entirely on technology, as we know from Boeing's failures. And think about whether the success rate is going to go from 50 to 90% with your new technique or technology, or is it going to go from 90 to 95%, and weigh the benefits versus the risk. And here you can see what's happened when you introduce this modular neck device, and it's led to tremendous failures. What are the features of successful technology? It should solve a real problem. It should not be radically different from existing technology. It should simplify. It should be introduced with diligence and surveillance, and the costs should justify the benefits. And before adopting new technology, consider the risks. What are the known knowns, the known unknowns, and the unknown unknowns such as trunnionitis, which came as a complete surprise to people dealing with modular implants. Consider the ethics of new technology. Why are you adopting it? Is it for research to satisfy your curiosity? Whom does it really benefit? Does it truly benefit the patient? Is it good for the patient, hospital, your practice? Remember fake news. Stop, use reason. More information has been created in the last 5 years than in all of human history. And therefore, we need to be deductive and logical in our thinking. We need to develop a research mindset. We need to be able to explain our pathologies. For example, we've shown these different phenotypes of knees. We've shown how the tibial plateau inclination leads to inherent varus alignment. Disprove certain myths. For example, we have shown that you do not need to release collateral ligaments in the correction of severe deformity. We've shown that obesity does not lead to malalignment if you use navigation. Try and predict complications and problems, such as what is the risk of malalignment in a total knee. challenge assumptions. We've shown that in fact just removal of osteophytes can lead to significant correction in varus deformity. Become a healthy skeptic and question everything. Recently we've written this systematic review, Is it prime time for robotic assisted TKAs? A systematic review of current studies. Innovate and find solutions for local problems. We've described a sliding medial condylar osteotomy to achieve gap balance for severely deformed varus knees, and likewise a lateral epicondylar osteotomy for rigid valgus knees. We've described how to deal with extra-articular deformity and how to perform a reduction osteotomy for severe varus deformities. So in order to ensure the success of arthroplasty in India, that it endures, and the legacy of all those doyens of arthroplasty in India who have contributed to its success, we need to work with fire and passion, like Prometheus, to learn and perfect your techniques, but to think, research, and scrutinize new technology and techniques before embracing them. Thank you.
Thank you very much, sir. That was wonderful journey, how everything began and where we are heading to, which is still more exciting and interesting. And having heard from the internal derangements to joint replacement, and how about not reaching there in the first place, is where our next speaker, our respected Dr. Mangal Parihar, would come in. Dr. Parihar is well known for his skills in deformity corrections, in treatment of non-unions, using the Elizarov fixators, the hexapods, and using these techniques to sort of develop solutions for our Indian patients locally, as well as imbibing technology from overseas and amalgamating them into usable sort of solutions. So I would welcome Dr. Mangal Parihar for his talk on his experiences and growth with Elizarov over the last many years in his practice.
Good evening. Today I'm going to be speaking about something new that we are doing in terms of deformity correction, how our planning and execution of deformity correction has evolved as part of the Wiroc curtain raiser. We used to plan on X-rays, on paper. Of course, we still do this in many cases, but this is two-dimensional imaging, 2D planning. And in case of oblique planes, etc., what we do is a 3D extrapolation. The issue that comes up here is the accuracy and reproducibility of the planning that we do. We've now started using some 3D planning software, which I think enhances our ability to plan and execute. Here is a patient with varus deformity in the tibia. And this is the conventional way that we would plan it on a program called a TraumaCAD. This can also be done on paper. Once we've planned the osteotomy, etc., then we have to plan where we are going to put the rings, what's going to be the length of the hinges, etc. So now what we do is use a software called TabPlan, which is sort of a work in progress. With this, 3D CT scans are converted to 3D models in this program. And you can look at various views, AP lateral. You can allow or take away other parts so that you're able to focus on this planning. So here I will take off the others so that we're just looking at the femur and tibia. This gives you all the parameters that we are looking for. For example, in this case, the MPTA is 79. LDTA is also abnormal, so they are marked in red. With this, we can also draw axes, etc., that are required for determining the fora. You can see it in AP, lateral, and any projection in between. Those small squares that you see there are the plane of the deformity. And as you see here, we can change the axis depending on what plan we have. This is up to us. There are multiple parts to this. What I'm showing you now is the deformity planning part. And here we've done 2 osteotomies to get the MPTA as well as the LDTA correctly. We can do an open wedge, closing wedge, neutral wedge. This has other advanced options. Once we've done this planning, we can simulate the correction, and the software does the correction in the 3D model, and we're able to check what is the resultant numbers that we get in terms of the length, in terms of the angles, the various parameters that we use for deformity correction. You can see the axis also, and you will be able to notice here the HKA has gone from 168 to 180. You can, in addition, fine-tune the angular correction that has been done by the original planning by a few degrees. You can add or change the torsion. So all kinds of facilities are available. Finally, we come to the implant. If you see, in this particular case, we've decided to use an Wiroc because we wanted to do gradual correction. So this allows us to place an Wiroc fixator of the appropriate size of rings, which is determined clinically. In this particular case, 160 mm. And then we directly get proximal link length for both the osteotomy 1 as well as osteotomy 2. You can fine adjust the rings, etc. And then when we click on surgery, we get the deformed frame that needs to be fit onto the deformed figure. So this helps us for pre-construction of the frame, and the frame goes to surgery for autoclaving, and all of this is done. The fixator is then applied at surgery. So that's the clinical picture of the frame that was made and applied to the limb. On the left, you see the X-ray. Here, you can see the full-length X-ray after correction has been achieved, and this is a close-up of the same. Another case where we decided to use an intramedullary nail, that is the precise magnetic nail. This patient had recurvatum as well as valgus in the proximal tibia and needed lengthening. But before putting in the nail, we needed to correct this deformity and get the tibia straight to put the thing in. So here is a patient who had a relatively mild deformity of valgus and recurvatum, which needed to be corrected accurately. We wanted to correct it with a nail, and therefore the planning was done. Which showed us with the CT, you can see the canal also, which is in a darker color. That's also derived from the CT. And So that's a lateral view, that's an AP view, and here we've got the axes which are drawn. That's the proximal axis and that's the distal axis, which needs to be collinear. So after the correction, this is what the bone will look like. That's on the AP and that's on the lateral, perfectly straight. But how do we get it into this perfectly straight position is the question. And we are planning to use a nail in this situation. So there's no really jig available for a nail. So what we decided was to put on a fixator. So now if you look at this, there are multiple options. You can use a monorail, adult or pediatric. You can use a multi-rail. So these distances are based on the LRS fixator. So this can be moved around up and down from here, and distance between the pins, etc., changed. So in the corrected position, we have applied a fixator in the position that I am sort of happy about. And then to simulate those same positions in the bone, if you look at this pin relationship to the long axis, you will find the same pin relation to the long axis. So through this jig, we can make drill holes, left with a jig like this, which is 3D printed and then given to us. So that's the jig that comes to us from the printing service, and that's the jig applied to the leg. You can see one Shan's pin passed through the jig. Using this and the osteotomy guide, which is here, we do the osteotomy, correct the bone, and then put the nail in. So that's the post-op picture of the nail in the tibia. You can see it's perfectly straight, and on the right you see the picture at the end of distraction. Another example of using an anatomic plate, a boy who had varus in the femur as well as a significant recurvatum. So which means basically this is a deformity. So here's a patient with varus and recurvatum in the femur. If you look at the lateral, you can see that there is a recurvatum in the femur. So essentially this is oblique plane deformity. I will hide the other bones so that we can focus on the femur. You'll notice that the parameters are abnormal, LDFA, tibial version, HKA is 161, which signifies significant varus. So just like we do the regular planning is done for this, and you find that on the to correct this, you need a wedge which is based not purely in the sagittal plane, not purely in the coronal plane, but somewhere in between. And the apex of that comes over here. This is not something that is very easy to do when you are doing it. So here you can see what is the location of that wedge, what is the we are doing a closed wedge, we can do an open wedge also if required, what is the plane of the deformity, and what is the size of the wedge. But the important thing is, how will you ensure that this wedge is placed perfectly as required? Then you can simulate the correction and look at the parameters, which have now been 107, that has come to 89. You can look at the axes, the weight bearing axes, in terms of where is the central axis passing, and be comfortable with that. It shows you as a number also here, the HKA, instead of 161 it is now 181, and so you can rotate it around and notice that the axis is slightly onto the lateral side, which is what we wanted. Go back to the AP, close this, and then you can choose an implant. There are multiple implants that are possible. Here we've chosen a plate and an MDF plate from the other side, because MDF is a medial distal femur. So we flip it for the other side, and this plate can be moved up and down. I'm not going to do that right now, but if I zoom in, I can position this plate exactly as I want, as I think it should be for this person. So what am I looking at? I'm looking at, is the plate well positioned here? Is are the screws parallel to the joint, and there is nothing which is abutting inside the bone, right? So this will be slightly away, etc. And once I've accepted the position of the plate, I can go for the jig. So the jig now essentially is going to make holes in the deformed bone, such that just putting in screws into these holes will allow me to fix the implant in this position. So in this you can see I can adjust the diameters, various diameters. So the pinhole over here is 4.3. That's the diameter for a drill bit for a locking plate. If we look at it from the side, this is how it would be. And also there are smaller pinholes for the K wires, which will guide my saw cut. So this is a saw cut which is kind of coming more anterior, and the apex is not directly medial, but the apex is slightly posteromedial, if you appreciate that. Right? The apex is over here. That's where the bone has got the least distance. So with this, then the 3D can be sent for printing, and we get the printed jig in theater. So here's a picture of the jig applied to the lateral aspect of the femur. Once the jig is taken out, we have the wires which will guide our cut. The wedge has been cut. The plate has been put in those holes which were originally drilled. Osteotomy completed. Notice that the plate is now in line with the tibia, and when it's brought to the shaft of the femur, the hyperextension will be corrected. Also on table, we check what is the LDFA, or whether the valgus has been corrected appropriately. The hyperextension also has been corrected, and that's how the leg looks like after it's been closed. That's the AP alignment, not a very good picture, but you'll see it on the full length X-ray. So this is what the jig can achieve, and this guy needed lengthening. So with internal fixation for the deformity, we could put a simpler fixator just for lengthening proximally. That's the full length before lengthening full length. At the end of lengthening, we restored his length discrepancy. That's him with a fairly comfortable unilateral fixator walking. 6 months. At the end of 6 months, the fixator was ready to be removed. That's his range. He's walking for what we call a stress test. When the connecting bar is removed, that's at the fixator removal. 6 weeks post removal, and that's his latest pictures. So, welcome to Wiroc. I welcome you to see this tech in detail in our deformity sessions. You will be able to ask questions and discuss all of this in person. And Wiroc always has many, many enthralling sessions. So please do sign up for Wiroc 2022. Thank you.
So thank you. That was Dr. Mangal Parihar, who is specialized in the art of deformity correction. And from deformity correction, we move over to the last subspecialty of tonight, which has been the most challenging one, the OncoOrthopaedics. And to speak on this is none other than the professor and the head of bone and the soft tissue division at the Tata Memorial Cancer Hospital, Professor Dr. Ajay Puri. He will tell us how he has laid down the foundation of the orthopedic OncoSurgery at this very institute almost 2.5 to 3 decades back, and what has been his experience over a period of time. Over to you, Professor Dr. Ajay Puri. Dr. Ashish, sorry, we can't hear the audio. Can you please increase the volume? Can you increase the volume more and start?
I think, can you replay it again, Maharshi or Poonam?
Yes, sir. We could not hear the audio. Please replay it with the right mix of audio.
Abhijit, do you want me to share screen and play it from my end?
Yes, sir. Sir, if that's possible, because it says it's file
Hi,
not
good evening,
supported.
everyone, and thank you for joining
Sir.
us this evening. Orthopedic oncology can no longer be considered a new field. but it is definitely one of the younger subspecialties. At the beginning of the millennium, it was a relatively virgin field with very few proponents. And it was possibly a combination of the bravado and arrogance of youth combined with the ignorance of fully understanding what this field involved that prompted me to take it. I was fortunate that I joined an institution that was dedicated to the treatment of cancer and with an ethos and culture that was and is still awesome, striving day in and day out to provide the best possible comprehensive care to these cancer patients. In the initial days, there were many challenges. Prime among them was the concept of having to rely on a multidisciplinary team to get the best possible results. This is an alien concept to us orthopedic surgeons who are so self-reliant and dependent only on ourselves to get the best results. Being the first full-time orthopedic surgeon at Tata Memorial Hospital, it was quite a challenge to procure all the complex instruments needed for bone surgery and to train the in-house nursing staff in their use and care. Here again, hats off to the institution and its personnel for going beyond the call of duty to aid and help. We were also fortunate to have very dedicated residents and fellows who worked tirelessly, including putting up with sometimes that were unrealistic expectations and demands. It is a matter of great pride today that all of them are now well-established orthopedic oncology specialists all across the country. Our multidisciplinary colleagues were also more than welcoming and smilingly put up with our idiosyncrasies. Diagnosis is critical, and the contribution of clinical findings, pathology, and radiology is critical in achieving a correct diagnosis. Our weekly orthopedic radiology pathology meetings were very popular and attended by colleagues from other institutes as well. And they have now formed the basis of similar ORP meetings that are very popular all across the country. Surgeries, as you can understand, were very complex. There was very little literature that was available, and the techniques were also not that well known to us, and we had to develop a lot of them as we went along the path. I'm sure there were mistakes, but hopefully we learned from them, and then that allowed us to make our results more sustainable and predictable. Mega prostheses are the cornerstone of any limb salvage program. Imported prostheses were very expensive and outside the purview of a large majority of our patients. We were again fortunate that an Indian implant manufacturer of repute combined with us and helped us develop and fine-tune indigenous prosthesis that has given very sustainable results. These prostheses are now used not only across the country, but in various Asian and African nations as well. We at TMH ourselves have implanted about 1,700 of them, and more than 10,000 have been implanted across the globe in these other countries. In addition to prosthesis, we have also been involved in developing many cost-effective biological solutions to complex problems. Reusing sterilized tumor bone, using pasteurization, radiation, or cryotherapy is now routinely practiced. Just because I speak about cost-effective treatment does not mean that we have shied away from technology. We routinely utilized non-invasive expandable prosthesis in growing children, 3D printed implants, and patient-specific instrumentation. Intraoperative navigation is also now routinely employed in our hospital whenever we need it, and we have been pioneers in the country in its use. Courtesy of the institution that I work in, there is no lack of social initiative from organizations and individuals to help contribute to the care of these unfortunate patients. We now have a robust system in place whereby if a patient cannot afford the cost of a mega prosthesis or an implant, it is covered by the hospital. Similarly, if any patient has had an amputation and needs an external prosthesis, then the patient gets an out-of-box amputation prosthesis at no cost, so that their quality of life is the best possible, even in spite of the fact that they have lost a limb. As important as patient care is training and dissemination of knowledge. From an unstructured training program, we have gradually evolved to an organized fellowship program. For more than a decade, we have now been running a 2-year fellowship in orthopedic oncology. Admission into this program is by a competitive national level exam. While young colleagues are always eager to jump into specialty training, immediately after post-graduation, my advice to those who are contemplating orthopedic oncology is to wait a bit. This is a field that needs that you know something about everything, be it trauma, spine surgery, arthroplasty, or pediatric orthopedics. So you are better served if you've spent at least 2 to 3 years practicing general orthopedics after graduation before you decide to jump into this field. Our fellowship program has regularly churned out surgeons with the knowledge, expertise, and skill to combat these complex issues. We also have a very healthy observer program that regularly attracts observers from all across the country and even overseas. In fact, it is so popular that we now have to actually regulate the number of observers to ensure that everyone gets a fair chance to learn. This dissemination of knowledge has led to an increasing awareness in orthopedic oncology across the country. This has been further contributed to by the multiple meetings, seminars, and conferences that are held all across the country. In fact, the role of the Mumbai Orthopaedic Society cannot be underestimated in this. We were always supported in any endeavor that we wanted to carry out under the aegis of the BOS. There have now been oncology sessions in every Wiroc for more than a decade. Along with the BOS, we have also jointly conducted a 1-week orthopedic oncology workshop where the delegates were given exposure to our operating rooms, planning clinics, outpatients, so that they were exposed to the full gamut of orthopedic oncology. And I think I can proudly say that today, the profile of Indian orthopedic oncology is well recognized globally. There are now multiple presentations, publications by various orthopedic oncology surgeons from across the country. From what was a mere handful of delegates in international oncology conferences, we now have a large number attending them, showcasing the work that is done in this country. Indian centers are also part of many global collaborative studies to try and standardize the treatment of musculoskeletal oncology and promote collaboration between centers. We established the Indian Musculoskeletal Oncology Society. It is a multidimensional and a multidisciplinary society, and it is different from other orthopedic associations and societies because it includes members from different fields, including sarcoma survivor representatives. The society has now grown by leaps and bounds. We have an annual conference which allows young surgeons to display their work and to establish collaborative networks. IMSOS has also helped in formulating guidelines for the Indian musculoskeletal oncology community, describing best practice policies that can be implemented, recognizing the constraints that are there in a country as vast as ours. The Asia Pacific Musculoskeletal Tumor Society conference was held in India in 2018, and it attracted numerous delegates. And these delegates from different countries welcomed this initiative of establishing locally practical evidence-based guidelines, which they could now carry and take to their regions as well. While this is all very encouraging, much more needs to be done. There is a paucity of basic training in the MS curriculum as far as oncology is concerned. This is a need that we need to address immediately and rapidly. And actually, I invite all teaching institutes to delegate some of their residents to attend these hospitals where specialized orthopedic oncology is occurring, so that we can inculcate these basics right at the beginning. We must continue this drive of awareness education. And this curtain raiser from the BOS is a great example that has provided a platform to highlight and showcase this specialty. Sarcomas are rare diseases. Generating evidence is difficult. But with a country as large as ours, with the numbers that we see, with the expertise that is available in our surgeons, with the innovative approach of our surgeons, and with a promise to collaborate with each other, we can easily become global leaders in establishing best evidence practices that can be adopted in any scenario, irrespective of the constraints that are there in healthcare systems. This is the best tribute that we can pay to our patients who have given us the opportunity to learn from them, and the best gift we can bestow on the generations to come. I will conclude by saying that the bravado and arrogance of youth has long been replaced by the pragmatism of daily reality. This is a very challenging field, and it's not for the faint-hearted. When you see our conference presentations, you see only the glory and glamour. You are not privy to the heartbreak and the depression that can sometimes occur when we are facing our problems and complications. When riding the wave, the highs are exhilarating, but the dips can be very depressing and discouraging. But believe me, if you stick it out, you will realize that nothing equals the feeling that, yes, you are making a difference every day of your life. I thank the BOS for giving me this opportunity, and I wish Wiroc all success now and always.
Thank you, Professor Dr. Ajay Puri. That was indeed a good insight into the work of onco-orthopedics that is being done at the Tata Memorial Cancer Hospital, one of its kind of institute in the country dedicated in treating cancer patients. So indeed, our night has been made memorable by the 4 speakers who spoke on their respective subspecialties and the journey that they have traveled over past 3 to 4 decades in their professional life. On the behalf of the organizing committee of Wiroc Max 2022, I thank Dr. Anant Joshi, a senior arthroscopy surgeon, Dr. Arun Mullaji, a senior and a renowned arthroplasty surgeon, Dr. Mangal Parihar, deformity corrective surgeon, and Professor Dr. Ajay Puri, an onco-orthopedic surgeon, for their valuable contribution in making tonight's curtain raiser a memorable event. Before we conclude, I would like to give you a brief update of what's up at this year's Wiroc conference. So on the behalf of the organizing team, myself, Dr. Ashish Phadnis, my co-organizing secretary, and Dr. Rajesh Gandhi, the organizing chairman, I welcome you all to the 57th annual conference of the Bombay Orthopedic Society. This year, we have shifted our venue to the Geo World Convention Center, which is located at the nucleus of the city, that's Bandra Kurla complex. Here, we'll be breathing in a fresh air and also bringing in new ideas to this annual event. Here, we are blessed with the large halls This is the Jasmine Hall located on the 3rd floor, where our scientific area will be spread over 50,000 square feet. So that is the Jasmine Hall. Also, what's new? What are we looking at the future? This year in the conference, we'll be having a 3D printing workshop where we'll be getting the glimpses of making different orthoses, plaster, as well as making implants in complex cases. How 3D printing is changing the world of orthopedics can be seen over here. We'll be going through the steps and the application, and also there will be a hands-on exercise. We have also prepared a separate robotic zone. Robots are coming up in a big way in the field of arthroplasty as well as spine surgery. Here we will be showcasing robots, and one can have a hands-on experience over sawbone models in these workshops. Also at this in this conference, we have got a virtual reality experience zone. It will decide whether virtual reality will churn out better orthopedic surgeon, and is it going to be a part of orthopedic training for the future. So there will be stimulation areas for both arthroscopy as well as arthroplasty and adoption of them in orthopedic training. As we take a step forward in orthopedics, we'll be also having an orthopedic surgical video theater where close to 100 surgeries will be relayed over a period of 3 days. Also, there would be interesting traumaplasty battles as well as debates which will be held in the main scientific areas. And just to take a break from the routine, we have also chipped in Kaleidoscope, which will highlight anything but orthopedics. This will feature painting, photography, sculpturing, fine arts, literature, music, sports from our members and delegates. This year, the presidential guest lecture will be delivered by our ex-Olympian hockey player, Viren Raskina, who is also the director of the Olympic Gold Quest, and he will be speaking on the journey to build Olympic champions. Also, the customary plenary sessions, the much awaited part of Wiroc, the prestigious R.J. Kathrak oration will be delivered by Dr. Sanjay Agarwala, and whereas the late Dr. K.T. Dholakia economics lecture will be delivered by a noted radiologist, Dr. Ravi Ramakant. Also this year, the theme for the late Dr. A.K. Talwalkar's symposium is pediatric supracondylar humerus fracture, and the convener for these sessions are Dr. Rujuta Mehta and Dr. Binoti Sheth. Also, we'll be having the man who was behind the Cheetah movement, getting them migrated from Africa to India, none other than Dr. Yadavendra Jhalla, a senior professor and the dean of the Wildlife Institute at Dehradun. He will be speaking on the journey and the role of the science in wildlife conservation in India. Also, for socializing and meeting our friends, there will be a Wiroc Katta where you can meet your near and dear ones. We are going to go beyond the conventional and going to have a memorable conference. There have been a wholehearted support by the executive committee of the Bombay Orthopedic Society, and the organizing team is indebted to them. So this Wiroc is going to be a conference with difference, a perfect blend of academic fest, innovation, and networking. I request you with folded hands to come and be a part of this action. Stay tuned for the live updates of Wiroc. So over to my colleague, Dr. Ashish Phadnis.
Thank you very much, Abhijit. And it has been a very interesting evening and really gives a glimpse of what we can expect to sort of talk to these people, talk to our doyens, our opinion leaders, our seniors, and brushing shoulders with them and participating in this annual event, which we all love, the Wiroc. So good night to everyone. And we hope to see you next week again with another episode of The Curtain Raiser. Thank you very much.